She had a right MRM and a sentinel lymph node biopsy and a TRAM. She's got some JPs. JP times 4, okay? 2 at the breast site and 2 at the donor site, right? The donor site is what? It's where it's where you've donated your tissue, your skin, your muscle, whatever procedure you're having. Okay. She's got a binder on at all times. Right arm is elevated on 2 pillows at all times. Gonna go home on a Rimidex or a Nastrozole. What meds do you anticipate will be ordered, priority nursing interventions, complications, and how do you prevent them? So, guys, in the future, like, that is exactly the way to study for everything that we do, right? If you can appreciate sort of that foundational level of how do I look at everything instead of just reading the words, right? I studied, I know this, I know that. This is how we want you to take it to that next level, okay? All right, so what do you want to tell me? What are you going to tell me about this patient who just had her modified radical mastectomy? What do you want to tell me? She had some.
Mm-hmm. Yeah,
So
she's missing a boob,
she's missing a, yes,
but she got a new one in.
she did. Okay, so talk to me about an MRM. What does it mean?
Modified
radical
mastectomy.
So what did they leave in place?
Pectoralis.
Yeah, they left the muscle, right? So she gets to keep the muscle there because we need that, right? Okay. This is all. You guys know, could there be like other pre-op, intra-op, post-op considerations here? Probably not intra-op too often. Will we do that on a test? But
Would
Okay.
they only take the muscle based on how the severity of the...
It's
if
pretty-
it's bad, they won't...
it's pretty rare that they'll take the muscle. They used to just take everything and then the chest wall looks like that. People can't. So I don't know if they even do, they probably would do it, but I don't know how common it is. I think it's less common. In my experience in taking care of patients in the last 10 years, I've only seen lumpectomies or MRMs. I haven't seen both. Okay. Ivan, do you need me to bring that up here?
Sure,
You're not
I can bring
pushing
it up.
back?
I can bring it up.
I'm kind of loud. Here, you can just put it right here. Okay, so what else do we know then, guys? What else do you want to tell me about her? Yeah, Jenna.
She's at risk for lymphedema.
Why is she at risk for lymphedema?
She had some of her,
Her notes taken.
her lymph nodes.
Yeah, so risk for lymphedema. So, how big is her risk?
It's lower than if it was,
If it was the other one.
the other
If they took a ton of them, right?
Yeah.
So they're really only taking,
Just a
1 to
couple,
2
yeah.
nodes. Okay, but she's still at risk for it. Okay, good. So we'll come back to that. Anything else about, the MRM? Right, we know she's got JPs in, which we'll talk about, okay? So why don't we talk then for a minute about risk for lymphedema? What does she have to do?
Keep it
Elevated.
Yep,
And don't put any blood pressures or any injuries to her
yep,
arm.
without BP or anything that would injure, right?
Mhm.
Say that again?
Compression.
Maybe some compression, although
She's
not
not
gonna cure it. Not gonna cure it probably.
correct.
What
Not
else?
report.
Can she shave?
with the electric razor.
She can only use an electric razor. What else does she have to do? But more lifelong, right?
Mhm.
Long term.
Come
Oh,
on.
lifting.
Okay, so careful with lifting. So if you go and you're on the test and you're like, oh my God, I don't know. Think about what are those things that are gonna injure the arm.
No tight jewelry, no tight...
Yeah, no tight on the arm, I'm just gonna say. Yep,
Avoid any kind of trauma to the arm.
avoid trauma. Yep. Could that be the sun?
Yes.
Yeah.
Yeah, right? So making sure that you're going through some of those lifelong, right, considerations, okay? So prevention is the best thing.
I have a question.
Yeah.
So for like not wearing any tight clothing or jewelry or anything like that, I know obviously like you can wear the compression, but should they limit the compression?
So compression, sometimes, it's pretty rare that any provider is gonna order that until there's a problem.
Mm.
Patients aren't gonna go home. And by that time, it's really more to kind of help, anytime you compress, like when we put ACE wraps on, that's to help with return, right? So that's kind of what that compression thing is gonna do. When we talk about the tight thing, it's more like tight at the wrist, right? Like, if I take this off of you right now, that would be a problem. Like, if that would be too tight, that cause a little sore on you, and then infection would set in. So it's that kind of stuff,
Okay,
as
okay.
opposed, good question.
Okay, so like watches, no?
Watches, yeah, anything that's,
Oh.
well, anything that's on there too tight. I mean, most times, I think what we say in the material is to just use the other side if you can.
Yeah, so I'm sorry, just real quick. So technically for like if I'm just trying to like
Yeah,
think about it, compression would be like more of like even all over.
yes, exactly.
Okay.
And it's not gonna be, compression's not gonna be
It's not-
restrictive at the wrist where you're gonna see that.
Okay.
Yep.
Okay.
He's taking
Oh,
it
yeah,
off
that's
now.
what I was looking.
Yes, Nick.
So if somebody did have lymphedema, would you put like something for compression to help with fluid?
Yeah, or somebody might go to a massage therapist that's certified in that treatment, but it's kind of one of those things that once it's there, like, this is never going away, right? Maybe some very, very mild, if somebody starts saying my arm, and they can't really, that might help, okay? All right, so that's lymphedema. I don't think we need to talk about JP drains, I think you guys get that. What do you want to tell me then about her tram flap?
So isn't that the one
Stomach.
that they go up under?
Yep, so there's two kinds, right?
Mhm.
What are they?
The one where they just cut it and then,
Yep, so the
Kinda stick it
tunneled or the pedicle,
mhm,
and then the free one,
yeah.
okay? And what do you know about those?
Is it
One,
the
doesn't it one, they
respiratory
take
one?
muscle and one they don't?
Yep, so, well, it's the amount that they take,
Yeah.
right? So with your pedicle flap, they're gonna, take the entire muscle.
Mhm.
So, entire rectus abdominis, right, which puts them at a risk for what?
Hernias.
Risk for hernia, because we're cutting into the muscle. This one, the free flap, they only take a portion, partial of the muscle. But within both of them, what are we worried about with these?
Graft
With, yeah, so occlusion, meaning what, Nick?
like that there's good blood flow to the, to wherever they put it.
Yeah, because if you guys look, and you don't have to look now, but with the pedicle one, and they have to reattach blood supply, the other one, they just kind of stretch it, right? That's still troubling. So this is sort of clearly airway breathing, right? Circulation, but graft occlusion. So, what is it that we're gonna do? We can't prevent it.
No.
Can I prevent it?
No.
Probably not. I can help a patient prevent lymphedema. But the surgery went on and I don't know what's happening inside. So what do we do to assess that?
Ultrasound,
Yeah.
Say that again?
ultrasound.
So, or
Or
the
Doppler.
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 Yep. So we're gonna check Doppler. Doppler pulses, okay? And so when we're thinking about what would you expect,
For it to be
So-
warm.
so what would be a normal finding here? What would we like to see here after a tram?
Pulses and
Well,
So positive pulse, if it's 2 or 1. Yep, A, B, and C are all okay, and then that patient has a pulse. What else would help us know that flap is doing okay?
The coloring of it.
Yeah, that the color is what?
Pink or whatever.
Or depending on your,
Yeah.
what does pink look like on you?
You can't see.
It's harder to see, right? I think for somebody from a distance looking at it may see that it might even look a little darker,
Mhm.
right? But if we'll just say pink,
Mhm.
or a
like
variation.
Not, yeah, not discolored,
Yep.
basically.
purple.
What else would help us to know that thing is doing okay?
warm.
How warm it is.
Yeah, so the temperature, that it's warm. So if it looks okay color-wise,
Mm.
and I can feel that it's warm, if I can't feel a pulse, would I still have to call a provider? Yeah. Right, that's huge. But not running to the phone where if it's cold and it's dark and there's no pulse, I'm a little more concerned about that, right? Okay? So when you see this and you think about that, okay, good, right? What are the abnormal things would be, right, that it's cold, it's discolored, okay?
So question, you said if there's no pulse, it's still notify the provider, but if there's a temp, if it's color like.
No, all I'm saying is, and I don't want you to write, I want you to think about this instead. If I go in and check it and it's warm to the touch and the color looks good, and I try to find a pulse and I can't, I'm not running to the phone. I might call somebody else in and say, hey, you know, Rita, can you come in and check this? I can't find it. It's not like urgent because it still must be getting some blood to it. If I go in and I check it and it's cold and it's dark and I can't find a pulse, I'm not calling any of you in to help me.
But
Because-
any of those three being absent is still a concern, correct?
Well, if it's cold, that's a concern.
If it's the color.
If the color is off, that's a concern. If there's no pulse, I'm just saying I have to sort of critically think about it. If it's good, if 2 out of those 3 are there, I'm gonna have somebody else come in and assess with me. If I can't find and all 3 of them are wrong, like I'm just going to call. I'm not getting somebody else in to tell me it's cold, right? Or that it's, dark in color. But again, you can't remember, those are like those critical thinking things that you just sort of have to like weed through. Okay, so tram, anything else about the tram that you think is important for me to know? Or for you to know?
Would they manipulate, would you say the bowel?
Say what?
Would the bowel be manipulated? Or no?
So, no, the bowel, because they're just going towards the muscle. Now,
Hemorrhaging?
yeah, hemorrhage, of course, absolutely. So all those other things that we're not even going to go through right now. Now, while they're not manipulating bowel, are they in that area where maybe pulling out a portion of the muscle disturbs the muscle? Would this patient be at risk for an ileus? Sure, but so would a lot of our patients, right? Okay, what else does this patient have done?
They have a lot,
Let's see. Oh, she's gonna go home on Arimidex. Or anastrozole is the other name for it, which is the one that'll be on the test, anastrozole.
Anastrozole is the one that's only for postmenopausal.
Postmenopausal. So we would assume, can't say an age, but if she's on this,
She's probably older.
we would, well, not necessarily, because many women go through menopause in their 40s.
I don't like that.
I'm just saying. But I wouldn't assume age, but I would assume menopause, right? What if this is a woman who had ovaries removed
Yeah.
in surgical menopause? So, postmenopausal. And what else?
They're estrogen.
Do you think we're really going to ask you about the physiology and how it differs from tamoxifen to anastrozole? Because tamoxifen is the what?
Post or.
It's that blocks estrogen, right? The other one has to do with the androgen.
Yeah.
That's physiology. I don't care if you know that, like I think you should know it, okay? But what are the things that I want to know that you know?
It's rather positive for.
Oh,
Yeah, well, that's one. Hormone therapy.
there is only one thing that you always have to think about with a medication.
Side effects.
Yes, what teaching are you going to do? So when you're thinking, what should I, wonder how they'd ask a question. It's all related to teaching, okay? And yes, Channing, it is side effects. It is what's it for, right? What do we do if there's a side effect? Okay, so side effects and what might be the nursing interventions. I'm not going to write them all up there, but you guys can tell me some of them. What do you want to tell me?
Hot flashes.
So they might have hot flashes. We don't have a big nursing interventions for that, right? Women who have hot flashes
Carry a fan.
that are, they carry a fan, they change their clothes, they don't dress heavy. What if they have hot flashes that are so severe they wake up all night and have to change, this happens, change their sheets 3 or 4 times.
That might be concerning because of,
Yeah, that's a problem.
from body.
It's a problem, but what do we do to treat them? They probably would go on hormone therapy for that. Can she go on hormone therapy?
No.
No, because hormone therapy puts you at risk for
Breast cancer.
Breast cancer. Okay, so that's not necessarily testable material, but that's the only thing that we could do for hot flashes. People can take, I take that back. People can take supplements, like, you know, different natural things. I can't remember which ones are the hot flash one or the menopausal ones, but anytime we put somebody on one of those medications, what do we have to think about? The risk for what?
Cancer.
Bleeding.
Which
Yep.
which one?
Oh, the G's, the ginkgo,
Oh, yeah.
you know, any of those. Okay. What else would be a problem? Don't be looking at your notes. I want to know what you know. Anybody remember any other side effects? If you
No. I
don't,
remember the
which
side
one?
effects for the other one, but I thought they
Okay.
were similar.
Which is,
they're similar, but when you have two meds that are similar, let me tell you what happens on the test.
You messed them
You
up.
make a mistake because you mix them up, and they are not 100% similar.
is this the one where, or is it the other one where you have the vision changes, or? What am I thinking of? Is it
There was a question somewhere
Yeah.
about
Yeah.
about
vision
visual
changes?
acuity and it being,
Yeah.
Where was that? I didn't send you that
Hesse.
one.
it was Hesse.
Yeah, well,
Yeah.
forget that, because if
Okay.
it's not on our, look, I can't, that's the problem with Hesse. I can't control it, because we don't teach every last detail. So when you get to a question, and you go, oh, visuals, we're never gonna ask that, okay? You take what we have in here, okay, because we, yeah. All right, so what are some of those other things?
Weight
Weight
gain.
gain, joint pain,
Yeah.
Half
So-
fractures.
yep, making sure that you go through
Those are the
those.
same
Edema.
But the big, but they don't, the difference is thrombophlebitis, endometrial cancer,
Oh.
right, for the tamoxifen,
Okay.
okay?
Yeah.
Bone pain, so I'm telling you right now, we don't have that many medications on this test, you better have them clear.
So this one, the main
Just saying.
concern is bone pain.
No, that's not the main concern.
Okay,
Weight
so there's
gain.
all
Any of them
yeah,
are
any of them.
concerning,
Any
yeah.
of them, okay.
I mean, well, if you're looking at an anastrozole, I might be super concerned about the fact that you might have a fracture that, I don't know what, it just happened, right? A pathologic fracture, we don't know. Am I concerned about your nausea? No. Now, if you have nausea and lots of vomiting, that's concerning. Am I concerned about vaginal dryness?
Not really.
No. I'm gonna be more concerned about that than you fracturing something and you dying from an embolism, whatever, right?
Yeah.
That's not, so, peripheral edema, put some Ted stockings on you. So, we don't necessarily sort them out like that in this handout. Okay, anything
Which one
else?
is concerning? I'm sorry. to
What
cut
is?
you off. You said the fracture is concerning and
Well,
what
anytime
else?
somebody has a fracture, that's a huge concern.
And what else was it?
No, I think that's the only big, I mean, the rest of them are,
Very, like joint pain could be arthritis or whatever. it
yeah, I
is.
mean, I am concerned about a fracture because
Fracture.
depending on what bone you fracture, you can have an embolism from that, which you'll learn about in the next. Okay.
Sounds very exciting.
Yeah, oh, musculoskeletal. Hate it. Don't love it. Don't love it. All right, what else with her? Arimidex. So we kind of talked about some of the complications. I know, Nick, you said occlusion. Somebody else mentioned what? Hemorrhage.
Oh, yeah.
Ugh. And then those other ones that I think are ridiculous. Infection, pain, right? Ileus, all those other complications. Okay? All right, okay. That's just good on that one. All right, endometrial cancer metastasized to the kidney. They have a neck tube in place. Oh, neck tube. Chemotherapy, Mediport, left lung punctured, chest tube. Okay. Endometrial cancer, that's cancer of what?
The
lining.
Of the uterus.
Yep.
You guys, I was paying attention
Now,
yesterday.
it doesn't say here what the treatment was. It says they did chemotherapy, right? Which may have been the only form of treatment that this patient was gonna have. What else might they do for this patient? What other surgery could this patient potentially have for endometrial cancer?
Like
They removed the cervix.
Ofro something.
Well, what else?
Hysterectomy.
Hysterectomy. Now, we don't tell you that here, because I don't know if she had one or not, okay? But if she had a total abdominal hysterectomy, they can do it how? They can do it laparoscopically, they can do it vaginally. What, yes, Emma?
Not to get too distracted, but what's the difference between endometrial cancer and uterine cancer?
So, typically when we think of endometrial cancer, just sort of the lining, uterine could be more involved than that. Yep. Okay, so if she had hysterectomy, again, what do you always think of first? Airway, breathing, circulation. So what are we worried about for her? Hemorrhage?
Yep.
Is she gonna have, an IV? Like, there's not a whole lot for the uterus, right? There's not a whole lot.
No kids.
Well, interesting.
Natural hit, like she can like, right, you can donate an egg still.
She,
Well,
yes,
no, you can't, if you take it out, then she doesn't have a.
if the,
But
right,
a hysterectomy just takes up the uterus, right?
right, but, and I might have emailed you, because I was like, kind of half,
Half asleep.
no.
Yeah,
No,
awesome.
if they take out ovaries, and they take out fallopian tubes, and just leave you with the uterus,
Mhm.
like the house for the
Yeah.
baby, the fetus, whatever, they can do in vitro.
Yeah, but if they take the uterus out.
If they take the uterus, you got nothing. Yep. Okay, so hemorrhage, so nothing else really involved with that. Okay, so what else do we have here? Why did we put Neph tube up here? What should you know about that?
It's
Right,
in the back, it should bleed.
It goes right into the renal pelvis. It could bleed, there could be blood in it.
Yeah.
What do you have to do to it?
Flush with 5 mLs of fluid.
Yes, you have to flush with 5 mLs.
Make sure
Okay.
it's patent.
Yep, now why did you say flush? This is I don't want you to feel like, Jackie, why are you asking me? And not irrigate. Do you remember the differences?
Because you don't pull back.
Yes, so the flush, and you're
Look
right,
at you.
flush 5
Oh, yeah.
milliliters, just a little bit to keep it patent, and then we just kind of let it drain. We don't pull back because it's right in that tiny renal pelvis, which, so, good. So how do you assess a tube? Anytime somebody has a tube in?
I'll put,
Oh, yep, so start where?
What outlet, yeah.
Start with your patient, so
Oh,
start
oh, yeah.
Start here with the patient. And if you do that, you'll never miss anything. So what do I assess? The site?
Then-
If I can see it. If I can't see it, what do I assess? If I can't see where that
The-
tube
the
went in,
dressing.
Oh, the.
Yeah.
Okay.
or the dressing, okay? Then what?
The person. I mean, the drainage.
So then I'm gonna look at the drainage,
The tube.
right, tube first, which you might have, yep, tubing for patency. Then what?
Find the bag.
Then you're gonna look at the bag and you're gonna know what?
The color, the
Color?
consistency.
Maybe
The amount.
consistency, the volume,
value.
how often I have to
Change it.
empty it, okay? All right, Mediport,
Central line.
it is a CBC, very good. What else should you know for this test?
Sterile.
Gershon.
It's a sterile, yep.
It's a hip needle, right, or Hoover, I don't know.
The Huber needle, right, it's the needle that kind of
It's a little.
has that angle on it, you know?
Is that the small, is that called
Yeah.
small bore needle?
Yep, and it's called a non-boring because it goes in and it doesn't take out like the plasticky, rubbery stuff that's in there with it, okay? What else do you want to tell me that you, that looks like a number 7. What
Sash.
else do you, yeah, it is a sash. So, you come in for your treatment, whatever, we're gonna do saline, administer your chemo, saline, and heparin at the end. Good.
They're all sashed except for a pick.
A
Well,
pick
pick-
can be, Nick, I will tell you, probably on most surgical units, you're gonna see Groshongs, where it's just SAS,
Okay.
is much more common. Now, you might see something called a purple power pick. That's a pick line that is a non-Groshong, so they can put contrast and jam it right in really fast. But for the most part, but if we will tell you, right, if we say your patient has a Mediport in, I'm not telling you Groshong or Groshong, because you should know that. If somebody has a pick line in, we probably would tell you it is Groshong or not, because that's the one that can be beat.
Because everybody I seem to ask, they don't know
What
what I mean when I say it.
Yeah, of course they don't. It's a shame. They probably don't know this, but they know what they have to do, they just don't remember why. Do you know what I mean? I would hope. Look, there's a lot of things nurses forget when they get out of school. I told you guys I had a patient not too long ago who was on TPN, lots of glucose, and what was hanging right next to that patient? A bag of D10. What are you doing? D10 is only for what?
When it pulls out.
TPN.
When it pulls out in yeah,
TPN.
okay. She's like, yeah, that was kind of confusing. Frightening out there, people. Call me, I'll be your nurse. As long as you're not having a baby and you're not at psych, I can be your nurse. Okay. However, this patient, right, so we get all that, had a little problem, right? Your patient had a problem with what?
She got her left lung punctured.
Yep, what's that called?
Uh,
Pneumothorax, right? Does that happen like 10 days later?
No.
No, it usually happens just as we have written there on insertion. So she's got in what?
Oh, chest tube.
She's got a chest tube in, and of course my, picture won't be great, but here's your patient laying in bed, right? Here's the chest tube. So, what's the first one called?
Huh?
What's the first?
Isn't that for draining?
Yep, so drainage, but we use a different word, typically. Collection.
Oh,
Yep.
collection.
Collection. So what do we expect to see there?
Fluid.
Fluid, and what color is it usually?
Pink.
Pink, bloody.
Yeah.
Okay, we're not gonna go through every last detail about amount, but I would write on a script, yeah.
If it's just a puncture, wouldn't it just be air?
There's usually some blood in there as well. Yep. Okay. So, is that all we expect to see there? Yeah, right?
Mhm.
So we have to assess INO. Okay. We'll come back to assessing our patient in a minute. Okay. What's the middle one called?
Is that the bubbling one?
Yeah, I don't know, is it?
Is it overflow?
It is, but what's it called?
I don't know, I just know there's 3 chambers.
It's a water seal,
Water seal.
right?
Oh, I thought that was the other.
The last one is called the suction control, okay? That's hooked up to suction on the wall. So, write down,
Okay, I'm right.
go through chest tubes.
Okay.
What do we expect to see in that middle one? Somebody said it.
Up and down, bubbling.
Up and down. We won't word it like that. We'll call it titling.
Yeah.
Up and down as you what?
Breathe.
Breathe. Okay? And then in this one, you might see a little bit of what? Bubbling. Okay? If you see the word vigorous, right? Lots of, no, none of that.
Would it
Okay.
be continuous bubbling?
Yeah.
Okay.
So if you have a patient now with a chest tube, how do you assess that patient? Start your patient and work out, right? What are you gonna look at?
So collection is always,
Okay,
I'm sorry.
Go ahead.
Collection is always towards the patient, right?
It's the closest one. Yep. So we're gonna do airway breathing, circulation, right? What else are we gonna assess about the patient?
Lung sounds.
Okay, so maybe lung sounds, and then, well, yes, of course, lung sounds, you're right. And then, start at your patient and you're gonna look at what?
The incision site?
The site, if you can see it, or the dressing. You wanna make sure that what's going on with the tubing.
Yep, that's the patient.
Peyton, and that the tubing isn't like in this big loop on the ground, because then nothing's gonna drain, right? We usually try to stretch it out so it goes along the bed there. Okay, what else?
That it didn't slip out. The tubing didn't slip
You
out.
just looked right inside my head, right? So what if it falls out?
If the,
Sterile water?
if
Falls
it
out of the
slips out,
patient.
You have to do
Yeah,
the
put
gauze
these over it.
on
Yeah,
three
when it
sides.
falls out of the patient,
Yeah.
But
But
the gauze
itself.
so you're gonna put the gauze and do what?
Tape 3 sides.
Tape on 3 sides.
And then isn't that when the tube, then you would put it in a sterile water?
If it falls out of the
Yeah,
chamber.
that's what I was thinking.
Yep.
Okay. Oh.
So if it falls out of the,
Not a
falls
chamber.
out of here,
Not
then
out
we're
of
gonna
the patient.
use what, like a container of saline.
Would a person have a chest tube for another reason than anything with the lungs?
They
Gauze.
could possibly have one for like a pleural effusion, something to do with cancer. Yeah.
Is
Yeah.
that like comfort care patient on my unit and he has the chest tube and I'm just
Yeah.
like, he's there for congestive heart failure.
Yeah, you can have like fluid that builds up in the lining there called pleural effusion, which we see with cancer patients. So, yeah.
So when you put the tube in the sterile water, is it still 20 milliliters?
No, you only have just a little container, and then you gotta go do another setup.
Oh, okay.
And the whole thing is trash after that.
Whole thing's trash, gotta get new one. Hope you have one on your unit. All right.
But we
So,
don't put that back in.
saline
The provider has to
container?
do that.
Yeah,
No,
sterile
if it falls out of here,
Yeah,
if it
that's-
falls out of here, nursing could do that.
No,
You're-
yeah, but
Yeah,
like-
but if it falls
yeah,
out there, yeah, provider's gonna have to
Yeah,
come back up.
How do you have to find a new chamber?
I would, if you got that 3 sides taped and you have sort of that even, you probably could have a half hour, I would imagine. I would hate to say much longer than that. I guess ask these great questions that I never think about anymore. Yeah, most nurses that are gonna work with these are gonna put one together in like 10 minutes, right, and just have it done.
But it's definitely something we have to like do something about
Yeah,
immediately.
yep, okay. All right,
Just-
nobody needs my pictures here, right?
Let's take it.
Absolutely,
Just
somebody take that
Can
picture.
you take a picture?
You can take a 5-minute bathroom break.
And then-
5 minutes, that's all you get.
What's the- what's the
All right, 5 minutes.
How do we change it?
Section.
The section?
Far away from the patient.
Yeah, definitely all get chest tubes.
Chest tube, right?
Yeah,
I'm going to
chest
that
tube all
again,
day,
huh?
I don't remember
But I
anything.
can't, I
I
just
don't
don't know.
I was reading it, I was like, oh, no.
General.
Yeah.
Clothes.
Yes.
Globally.
It's saline,
One.
med saline.
Thanks for asking, Melissa, I'm gonna let you guys go. Yeah,
Saline,
you're fine. Go
med
ahead.
saline, heparin.
Mhm,
Okay.
mhm.
Because like, I remember in the chart, I was like, oh, they're all non-Grisham except for a pig.
Mhm.
But like literally, like everywhere I asked to get clinical for a
Nobody
job,
knows.
nobody knows anything about like essential line. And I'm like, wouldn't you need to know?
Probably won't need it, I don't know. I feel like-
But, you know, depending on which floor you work on and you don't deal with them often.
I know, I'm like,
I don't need to know that right
just
now.
in case.
You know what I'm saying? Like,
I think I read it.
and that's the whole reason
Yeah,
why when
that's
we
how I
graduate, I don't wanna go straight into a specialty because I'm gonna forget all this stuff. I wanna work on a nursing floor for like at least
Oh,
a
I
year.
hate that.
Look, I take a picture.
I wouldn't like it either, but
Drawings
I
are
mean,
so
even like working
fabulous,
like,
right?
when I go up there, some of the nurses have just started, they just graduated. and-
Did you have to work over the weekend, James?
They like.
Did you work in the operating room over the weekend?
Yeah, it was there Saturday.
You commit it to memory, take the test, and you're like,
The Chang was there,
and they
Anything
start working
exciting?
psych,
but the
and,
Chang did. I don't think.
you
they
know,
did.
like I'll take somebody's O2 set, and
I don't think, I
they'll
mean,
be like,
just
oh,
Just the usual,
you know,
no,
they're at
some
89, and
ortho.
the nurse is like, well,
Some general
what do you
ones.
want me to do? And I'm like, yo,
Oh,
need something?
Gunshot broke
Oh.
the femur.
Something.
Yeah.
Gunshot wound to the femur?
Did you work this weekend?
yeah.
Ah,
You-
got that extra
oh, wow.
20,
Yeah.
20.
Dude, I showed up
What are you
on
gonna do?
Friday, and I had picked up a 4-hour
There's
shift.
something else. Can't remember what they
And
pulled out.
I wasn't on the schedule,
Mm.
but I
You
showed
guys
up.
probably get a few
And they were
gunshot
like, oh,
wounds
like, we
down there,
could
don't
really
you?
use you, and I,
He probably
looked
didn't
at who
have-
I was
if-
working
if-
with,
if
and I was
it didn't
like,
fracture his femur,
I wanna
he
go
probably would've
home.
fallen.
Yeah.
but I stayed, cause I remembered the extra
Do
incentive.
it
and
when
I
it
was
comes
like,
out,
you
is
know,
that, does
I
that,
can
well,
stay,
then
I
go
can
to
stay away from these
pathology? What
people
do they
and
do?
just talk to the patients
Oh,
for
you
the
go
next
back
4
to the
hours.
probably the forensic?
So, yeah.
It depends, yeah, because any gunshot that comes up is always restricted, like you can't see any information unless you go in their chart yourself, so like.
work.
Yeah, and you have to be careful going into their chart, right, if you're not somebody who needs to be in there, yeah.
Oh, God.
Usually, yeah, usually what they'll bring to the cops if
And
it's
expensive,
like
right?
an emergency gunshot where
Overnight?
It's holiday pay.
Yeah.
Don't get
someone's.
overnight.
$12,
They
yeah,
usually wait
extra
up there,
$1.
sometimes
I was
they
gonna
go.
say, you probably see some officers that are up there, right, with some of these folks, especially if you're worried about
Holidays, so I made 36.
retaliation.
Yeah.
Wait, you
Somebody-
guys
you know what I
are
mean, like,
$10.
So-
No.
Yeah, a lot of times they'll come up.
They offer it.
Yeah,
I've
they
only
offer
seen
it.
one or two
Oh.
places
Yeah,
there. We'll give
because it
them
was
like
the only time
the
for
cheap
the
money
young
suits
people.
and they'll come
That's
in.
right.
They actually come in
So,
there.
like,
I've seen it once or twice.
changes
Like usually,
and
like there's like a red line for, you know,
Mm.
they'll stand right there and pass it
Yeah.
here or whatever.
Yeah.
They'll wait for the charge nurse to bring the bullet to them.
I could get you
It's
into
like,
the RC.
So it's definitely
Yeah, the
sometimes
psych unit.
they're just not there at all.
Yeah, you can,
Yeah.
or you can,
So that kind of
you're per
gunshot,
diem, right?
couple days
Why don't you
before we
split
got
time
operated
between you and
Okay.
St. Mary's? You could come work with us.
Mhm.
And
honestly, like, I don't know where I wanna go.
yeah, they weren't
I
there.
hate it.
Yeah.
But I wasn't in the room for it.
Honestly,
Can you
it's like,
stay in a room if you want,
I-
if you're
it
interested,
really
like,
is.
okay, hey, can
I
I
was
watch
thinking
this
about
there, are they pretty cool
quitting
with it?
too,
Yeah,
and going
so,
to med surg, but I
um,
just was, I was annoying enough that
like,
they ended
peanut
up giving
implants they're
everybody
weird about.
raises.
Well, other
I'm
than
like,
that-
more, they like
Like,
put everybody
Who
up
does
to this
those,
like
Janetti?
weird care navigator.
That's what, yeah.
Yeah, I was so annoying about it that I was
Usually
like
urology.
talking to
Like-
all
like
my
that
other
was a
techs
weird
and
one.
talking to
Oh,
my
yeah, yeah.
he
CNLs.
did my mom.
And I mean, it was
We call it a
ultimately
pilot.
Colin that did it, our director,
Yeah.
but he moved everybody
Yeah.
up
But yeah,
to
so
But
like.
for the most part, they know
bachelor's
doing it.
or
Yeah.
2 years
So-
experience.
Actually, I got a funny story about that.
Yeah, 19 now?
I think we're at, I think because, I think you get extra because you're per diem, right?
Yeah.
So you get more, but we're all going up to 18.
Nice.
Which is still
That's still good.
great. And in psych, especially for now, for the next like year or so while you're in nursing school, you can still practice all of the
And she was drunk.
like,
So
like
the night
certain
before,
things.
Mhm.
But it's also not
the
a
night
huge
before,
headache.
Yeah.
Like if you
she was-
can, my
she had
biggest problem is not
drank
the patient.
before she came
It's
to the
the
morning.
patient. where I'm just like, you know what, I'm just gonna do music group and like hang with the patient.
Yeah.
Not talk to anybody that I work with. They're all acting like huge babies right now.
Nobody ever needed to know.
So I see the X-ray that put that on the, had Dominic a bunch of questions. They're kind of just talking about a lot of.
Yeah.
Like Lindsay Clinical Lindsay? Nice.
So.
Before you go to sleep, just smoke. They hate when people smoke, because it's hard to see.
I told Lindsay I'm coming to work with her
So-
when I graduate.
Even her fentanyl, so
I'm probably trying to go work there right now.
You totally
She already
should.
put the mask on,
It's
so
like,
I'll give you something to
if
keep her safe.
there's one time, it's like hours between the nurses and us. Like, if I did it to my unit, the charge nurse would murder me right then and there.
I'm sure there's a lot of peer reverence in that.
Something like, she's a CNL, right?
I thought-
Or she's like
and I
a,
was-
she's in charge. But she's in charge, you need somebody else that's gonna be like, okay, like,
That is great for you only say.
so
It
we're
is a
gonna
little
call,
light.
instead of just like, we only,
He's a naughty
go ahead and do everything, we're just
All
gonna
right,
sit up here and do nothing.
okay.
That is,
So I'm gonna-
that will make or break your birthday.
Yeah, first.
I'm gonna erase these two. Let's go over here though to the prostatectomy one before we do some of these other ones. Okay, so prostatectomy was part of what we, you just had in my conference there, okay? The last one. So what do you want to tell me about a prostatectomy? I know you didn't write anything down about it because it wasn't one of the case studies. But what do you guys want to tell me about it?
You take the prostate out,
Okay, so radical prostatectomy, we're taking the prostate out because of what?
because it's cancer.
Because of prostate cancer. Sorry, I'm just finding my notes because I don't want to miss anything in case there's something important here. Okay, so it's removal of the prostate because of cancer, right? Okay. So what is it, so where is the prostate gland?
It's between the bladder,
bladder.
and the
And it runs around through what?
the urethra.
Right. Okay, so if they take this out, yes, of course, airway, breathing, circulation. What is this patient?
Nerve damage.
Okay, so the patient has concerns about nerve damage. They don't have concerns about the cancer.
Yeah.
Well, they do. Nerve damage because of what? Two things. Erectile dysfunction and
Peeing.
incontinence, right? So when they do these surgeries, if they use the Da Vinci, right, they use the robot, they hope they can spare some of those nerves, okay? All right, so what else comes out of the patient, part of it, and they sort of have to reconstruct?
Part of their bladder.
Yeah, they have to partially reconstruct the bladder. So, this patient is gonna go home with what? Home with what?
A Foley.
A Foley. And they wear that during the what? During the night. And what do we usually give them during the daytime? A leg bag, okay? For daytime. Now, they could wear the Foley, but most of them aren't gonna walk around with that at home. Okay. So if we think about it, now when they're in the hospital,
Is it long term or is it long?
no, it won't be forever. It'll just be until things clear out, and swelling goes down. So when they're in the hospital, airway, breathing, circulation, but what's a priority for this group of folks? What else are they gonna have? They're gonna have the Murphy drip. What order do you anticipate seeing when someone has a Murphy drip? How's it worded? How do I know when to use this?
Oh, if there's,
So continue,
Continuous irrigation.
if there's like a
irrigation, but how would I know? Continue irrigation when? When? What if your urine looks yellow?
Oh, until pink.
So
Or
urine
clear.
should be pink to clear. Okay, and when it's clear, people might turn it off. Why does this patient need all that fluid? Okay, so that's the order you can anticipate seeing, right? That's in your handout. Okay, so if your patient has a Murphy drip, write this down. It's 7 a.m. There's 2,000 milliliters in that bag, okay? Which is normal. They also have a JP drain. you go back in at 12 noon, it's been running continuously.
5 hours.
Yep, because it
That's what
wasn't
it
paid
said.
before, okay? And now what do you have to do when you go in?
Check the
So
amount
this
left.
is the credit. You have to check your bag,
Mhm.
right? So at 12 noon, your credit is now 1,000. What does that mean to you?
That means we put $1,000 in,
We put 1,000 mLs where?
into the,
Into the patient,
mhm.
okay? You empty their Foley now. And their Foley has don't say this out loud, has 1,650 in it.
Mhm.
You also empty their JP drain,
Mhm.
and their JP drain has 75 milliliters.
Mhm.
Okay, so take a moment and let me know what is their, so two things. One, what is their urine output? And two, if we had to total it up, what would be the total output? Okay, so take a minute.
JP. That's 7.5.
JP has 75 in it when you empty it. Well, I know you have the answer. You just see it, jeepers creepers. What is yours?
I don't understand what she was saying.
25.
No?
25.
You guys don't remember this?
No?
So this is what's going
I only get.
Okay.
Output, yeah.
Okay,
Chart,
so
yeah.
your bag has 2,000 in it.
Right.
Okay,
You come back in at noon and it's been dripping.
Mhm.
correct.
There's only 1,000 left.
Mhm.
Okay, so.
How much went into the patient? Probably 1,000, right?
Alright.
But that doesn't matter yet, right? Your
Correct.
Foley, you emptied it, has 1,650.
Mhm.
So.
Okay,
basically
so how do I know
650 is your-
What their urine output
You
is.
subtract the
Subtract the
1,000.
two.
Yeah.
So how much urine output is there?
650.
650.
650. Because 1,000 of that is what?
It's the Foley.
It's the
I mean,
CBI.
yeah.
It goes in and it comes out.
Mhm.
Now, don't ask, because we're not gonna try to trick you. Are there times when maybe you put in 1,000 and there's only 800 that comes out? Could they retain? Yes, we're gonna ask you that.
What's the 75 though, nothing?
So 75 is the
Just
JP.
JP. Okay.
Right, so their urine output is what?
650.
650. What if we said to you though, on a test, what's their total output? Not urine, you have to read it carefully. What's their total output?
1725.
725.
So,
That's what I said.
You said 1775.
1725.
It's not 17,
725.
because I don't get to take credit. That 1,000 went in and came out. It's a wash.
Oh, so you're not putting
No,
it in?
no, no,
Oh,
no, that doesn't count as, that's not output.
Wait,
Oh,
so
well,
it's
okay.
725?
So what is,
Not 17,
Oh.
right, because 17 is, it's just a wash. It went in, it came right back out again.
Because 1,000 we put in there.
Yeah,
Okay.
that's just,
It's
that's
not
like,
actual urine.
Okay, so you
just
should-
it's really nothing, it's just cleaner. It's
Okay.
just a cleanser.
Okay, so you
so
don't
what
count
is, at 7 AM, what's that 2,000?
That tells you how much, so,
You started
that's what you start with, that's called your credit.
Okay.
And I think that's the example we use, we tell you it's a credit. Hold on one second, yep.
Probably just overthinking this, but if it goes in and comes right back out, how is that input?
It-
I
No, it's not intake.
You said it was 1,000 input.
It,
Or did I?
you have 1,000 that went from bag here to their Foley. It's not intake. It's a wash. It went, it
Right.
started here and just came right back out. It's just a cleanser. Like, oh, so it's not intake. Now, if your patient retains some of it, that might be, you might have to put it on their intake. It's pretty rare. So it's not intake and it's not output. It went in and came out.
I think maybe I was mixing up credit and intake, maybe?
Yeah, so credit, so if we say credit, that just means that's how much is in your bag, right? If I said to you, James, you have a $10 credit, right, that's how much you have, $10. So that would be the credit.
So question, so the 725 will be the total output
Because it's their urine.
plus the.
Yeah.
Okay.
So before you leave, I would write that down, that problem, or take a picture of it so that you can then switch the numbers around at home and do it with somebody else, okay? Who's yours?
No.
Oh, what did I take? Yeah.
Come back.
Whoopsie. Okay, alrighty. What else about this group of people?
I can't.
Was there, do you guys still have questions on it?
I'm not gonna ask right now.
Are you sure?
Yes.
Okay, we can talk about it at the end if you want to, okay? All right, so what other things though? So that's one issue, is that CDI. There was a whole page of nursing diagnoses for this patient. What else are we worried about? So hemorrhage, right? And that's why we do that. What else are we worried about? If we're worried about hemorrhage and we're gonna irrigate and use this and assess for what, right, red bleeding?
Yes, occlusion.
Yep, but there is a nursing intervention that was on that nursing man, don't look.
So we're,
If they have sutures in the rectal area,
Oh, yeah, you want them, yes.
Say it again?
Still soft.
Eagle exercise.
so they might have to do, they might have to do Kegels if we cut into the perineal area.
Yeah. You need
But
still softeners.
They might need stool softeners, right? Because there's sutures there, we don't want them to push. Can we do a rectal temperature?
No, nothing up the rectum.
No rectal procedures, nothing.
No butt stuff?
No butt stuff. Oh, jeez. I should get that on. That was not Jackie. That was not Jackie. Most of those other things that are on there are pretty basic, all right? But the other one that somebody mentioned was Kegel exercises, right? Those are it's the tightening and contracting of the perineum, right? We think about that in terms of females who are having babies, they have to tighten that up. But people don't think about that a gentleman might need that,
No.
okay? And so, yes, Kegel exercises to help tighten up the area. And if you go, how do we do Kegel?
Yeah.
Well, for women, I think it's a
It's
little
easier.
easier because you have to think about the act of peeing and stopping. That's kind of the motion that bodies will go through, but you don't have to worry about that. Okay, anything else about, so let's say,
so you said the stool softeners is to prevent the sutures, right?
to prevent what?
The sutures from,
Yep, so here's what you guys have to think about. Like, what if I do surgery in that rectal area for any reason? What if they had a hemorrhoidectomy? What if I remove part of their rectum, their colon, right? What makes sense, right? Not just, and I'm not saying this to you, but not memorizing, like what makes sense, okay? And then there's a few other things like hormone therapy, but we won't have time to go through all of those things. Okay, so let's go back over here to another case study, but I want to make sure that we get to some of those tests over there, because those are
Quick question
important.
for you.
Yeah,
This
I'm erasing
administer,
over here. Say what?
the administer antispasmodic medication,
Right, so
what's that?
what does an antispasmodic mean?
to prevent spasms.
It's a muscle relaxant. We have not given you any that are testable, but, no, 214, no. It might be it is on the next exam. Did you look already?
No, but
I think we have Flexeril on the next one, a muscle relaxant. So this patient could be on something to help relax and prevent spasming. All I would expect you to know if it was a select all that apply was antispasmodic. Like, we're not gonna ask you which one until, as Nick well pointed out, Flexeril, cyclobenzaprine, which is a wonderful drug, will be on the next test. It's a little sedating.
Sure is.
I think of it like a mild, to me it's like a benzo.
Which one? Relaxer.
Okay,
Cyril.
so case study number 3. Let's see if there's anything super exciting here to talk about. I don't think so. Colon cancer, colectomy, ileostomy. Okay, so we're not gonna ask you what's a right hemicolectomy, what's a left, who's gonna have a catheter or an ostomy, who's not. That's not our call, right? We could say to you colon cancer, colectomy, ileostomy. So what do you want to tell me about the ileostomy?
Fluid.
Dehydration,
Electrolyte.
Okay, so we're worried about dehydration. Why?
because it's mostly liquid.
Yeah, because of where it lives, right? Okay, so it's mostly liquid stool.
Would you worry about electrolytes for that?
Yeah, you would. I was just gonna ask that. So,
Well, that and she's puking.
and she's throwing up. That's right. So, you have to worry about, I would say, anytime you see a risk of dehydration, or we tell you vomiting, diarrhea, you have to think about what? Acid-base imbalance. and electrolyte imbalance. And we're not gonna have time to go through those, and I don't think you need hours to do it. I think, remember, going through metabolic acidosis is where? Below, alkalosis is above. Yeah.
What is that saying next to dehydration?
Oh, just small intestine. Yep. Okay, so yes, good point. So how would you know if your patient was dehydrated?
Skin tuber.
Yeah.
Mucous membrane,
Mucus? So,
confusion.
skin turgor, even though I hate skin turgor, and I'll tell you why. What else was this? Oh, mucous membranes. What else? Come on, think, people. Everybody should have 10 answers for me right now.
Headache, dizzy.
Okay, so they might complain of a headache. They might feel dizzy.
They might feel thirsty.
They might complain of thirst. Come on, people. You're not giving me what I want.
High heart rate, low blood pressure.
Yeah.
Fine. then.
So
Fine.
decreased blood pressure, increased heart rate. What else did you say, James?
Well, I'm not sure, but I said sweating. I feel like,
They could be sweaty. They could also have a little bit of a fever, right, with that. So, their
Excuse me.
skin might have some changes. What else? Come on.
We doing labs too, or not?
Oh, maybe you want to check labs, because what might indicate a problem with dehydration?
Specific gravity.
Okay, specific gravity. What else? Come on. Put those brains on of yours. We talk about it every single week, and you say it every week to me.
Potassium.
What?
I don't know.
Is it hyper,
What did you say?
The creatinine.
What, creatinine and what?
Fun.
well,
BUN and creatinine, yep. And which one specifically is usually a better indicator of hydration?
Yeah.
No, creatinine is more the
Really?
kidney,
Oh.
kidney function.
The one
Oh,
time
so
I
it's
say.
fine.
When you have dehydration, if your kidneys are working okay, say you're a marathon runner, it's like 1,000 degrees out there. Creatinine's probably gonna be fine, but your BUN's gonna be elevated.
Oh.
Yep. Okay, what else?
Ah,
A high CBC or high HB.
Oh, so their crit could be high, right?
mhm.
Yep, that could be up in the 60s. What's the other one we have to talk about?
low urine output.
Okay, low urine output, and what else about their urine?
Concentrated.
Yeah, so it's dark. Okay, could their sodium be off?
Yeah.
Okay, so holy mackerel, one little thing of dehydration, look all the things you have to think about.
Mhm.
God, we nurses are smart, aren't we?
Yeah.
We are smart people. Okay, well, you will, you guys are way smarter than you were with nursing things than you were a few weeks ago, right? God, I didn't get this smart overnight, right? I didn't get this smart overnight, it took me 40 years to get here. Okay, so look at your electrolytes there, ileostomy, chemo, tumor. Okay, so let's talk for a minute about chemo, safety. What do you want to tell me? For me, the RN versus patient safety.
So for that, you need your time, your distance, and your.
Shield.
the other thing.
Shield.
That's
Ah, damn it.
radiation.
I knew it was one of those.
That's okay. We'll put that up here too. Radiation time, distance, and shielding. Okay?
Well, obviously
I know exactly.
protection.
Nick, I knew exactly what you meant by this. Yeah, so you want to dress the part, right? You want to dress appropriately, right? You got to have your cuffs covered.
Double glove.
Yep. So whatever those things are, follow OSHA. Okay? No drinking, no beverages, around the chemo. So a lot of the safety though, right, you have to, if you are mixing it, mix in appropriate, what? Location. Okay? If you're the patient, what are the safety things that we think about for the patient?
Well, you mean administering, like?
Yeah, so your
knowing their
patient's
weight,
getting, knowing their what?
Their weight, their height.
Their weight and their
Height.
height, yeah.
And their labs.
Yeah.
Yes, who said that? Okay, what other labs, Melissa, do you know?
It's the white blood cell.
Yep, so a complete CBC.
Yeah.
Okay, what else makes it
Vital
safe?
signs.
Vital signs, absolutely. What else?
Previous allergies or
Yeah,
how they
check-
tolerated the last.
Right, how did they tolerate it? Absolutely. What else? You guys know, come on, think. I'm getting chemotherapy, how do you keep me safe?
So if when you're administering they have to make sure like their port or whatever, however they're getting it is in
Intact.
good and
Yeah,
intact
so
and-
how do you do this? So you wanna make sure you check the site, but then how else do I know, like,
It's gotta be
Because
through
chemo will
central
burn.
line.
Flush
Has to be
and
what?
hold
Through
back.
central line, right?
it should be, you can do it, Jenny, through peripheral. Some folks will just go to chemo every week or a few weeks and have it put in. But there probably are some that they prefer a Mediport through.
But if it's a they say it's a vesicant.
They're all vesicants,
Okay.
they're all vesicants. Yep, you guys know this. You're
Uh,
close when you were saying, make sure the site, but I want a little more information about this.
If it,
How do, so I go in and I go, oh, your iPad looks great.
flush it, hold
I'll
back.
see you in 6 hours?
no, don't you flush
And you
it?
check every
Flush it,
hour.
hold back.
Yeah, so I know that's kind of probably what you were, yeah, it has to be flushed, but I gotta check
Looking for
this.
extravasation.
Check at least hourly, yep, check for extravasation.
What does that word mean?
Us- Go ahead.
So it's, okay, not, like, okay, you know how when we have infiltration that goes to surrounding tissues?
Mm-hmm.
It's the same thing, but the medications, like the high alert and how it responds to your skin, you'll have a reaction based on
Okay.
that.
Burn your
So the
skin.
burning.
Okay, anything else for chemo?
I noticed they all do, IVs, they set up IVs, is that a thing?
What do you mean they set up IDs?
Yeah, each patient had IV going when they were doing chemo.
When I
Oh, well,
went there, it was for like the pre-meds.
For the pre-meds,
Oh,
right?
okay.
Because if I just hook you up to your chemo and you have a problem and you need something else pushed through there, God, I'm telling you, you probably cannot push a steroid or Benadryl through somebody's chemo.
Hmm.
It's probably not compatible, so they'll have another line running.
Okay.
What else? And we'll definitely won't have time for this, but, so,
Oh,
I'm
don't we
getting,
also don't we push, antiemetics prior to chemo?
so antiemetics and any other pre-meds, and we don't go through a lot of those with you, but they'll get other things too. Yep, maybe for anxiety. What other thing that I'm looking at? I'm starting chemotherapy today.
Teaching,
Teaching what, Jenna?
side effects,
Yep. Side effects and what? How to,
how to, control them.
yep, and how to manage them. Same for radiation. So give me a common side effect and tell me a few things.
Fatigue.
What is it?
Fatigue.
So does it matter if I'm getting chemo or radiation? No. All cancers, almost all of them, whether they get treatment or not, right? Cells are dividing. I look at it like there's a whole lot of things going in my body that are dying. It's gonna make me tired, okay? What else?
Yes,
Stomatitis, mucositis.
Okay, so some oral problems, right? With the itis.
Nausea, vomiting.
Yep.
Yeah.
Nausea, vomiting, so diarrhea, constipation. Okay, give me
And then the hair loss routine.
Yep.
Alopecia.
alopecia. Give me something that we do for the oral itises.
Oral care.
Yeah.
So good oral care.
Brush.
Yep.
Lidocaine cream.
Lidocaine.
With the,
Saline.
Yeah, can I go buy some like,
with no
mouthwash?
alcohol,
Mouthwash, no, good, you guys got that one. What about food for these folks?
the bright diet.
So you could technically use it, the brat diet is especially for what?
Nausea, vomiting.
Nausea, vomiting, like diarrhea, right, that brat diet. But the orals, we tend to want them to have what? Things that aren't spicy, right? You can think about, oh my God, think about when you had like a pharyngitis, a sore throat, like, oh my God, would you have wanted a chicken wing?
Mm,
No.
yes.
And most importantly, that they're getting in plenty of things to drink.
So like a bland diet?
Yes, often a bland diet, yeah.
What's the B again?
Bananas.
Bananas,
Not
okay.
bananas, yeah. Okay, nausea, vomiting, you guys all know on Danzatron, right? Constipation, stool softener, right? There's, you guys know these. Alopecia, give me a couple.
Get a
Get a
wheel.
wig before.
Maybe you buy a wig before.
Or
Nice
shampoo,
hats,
talk with them
scarves.
about hair care.
Scarves.
Talk with them about
Cut the
hair
hair short
removal.
before you start.
Okay, anything else about this one? I don't think so. Okay, the next one. Ovarian cancer, I don't think we're gonna talk, I'm not gonna do that on the board, but let's just talk about TAH-BSO, total abdominal hysterectomy, bilateral self-injectomy.
No, that
So
means?
basically everything on.
Everything's gone, they took everything. So surgical menopause, right? What else? Vaginal bleeding, possibly, even though they might have done it laparoscopically, right? Vaginal rest, you guys read that in there, there's
Yep,
no,
intercourse.
Yep. But let's then just
Not
talk,
tampons.
exactly, let's talk for a minute then about the PCA.
Mm.
Because I think that's one of those things that's gone from our minds as well. So the PCA, what are some medications that this patient should be on as PRNs possibly, or other, what?
Naloxone, Foley,
Naloxone, Colace, what else?
Benadryl.
Diphenhydramine?
Yeah.
I can't remember the one that you just said.
Now,
What
she
was
said naloxone,
Mhm.
diphenhydramine,
Maybe Zofran.
Colace, Zofran, thank you. So those are the meds they should typically be on, okay, or at least have them somewhere in the chart. So if this patient is getting a PCA morphine dose, 0.5 milligrams every 10 minutes. Well, what we don't tell you on there, and you might want to write it down because it'll make more sense, is the lockout is, or the lockout is 10 minutes,
Mhm.
but the 1 hour max dose.
Mhm.
What would it be, do you suppose?
3, yeah.
That sounds like an awful lot, doesn't
It
it?
does, yeah.
3 milligrams?
Yeah, half a milligram every 10 minutes, that's a lot.
Yeah,
That's
'cause
a lot. What do we usually see?
point, is it one?
0.2 we usually see on our units. Sometimes 0.3 if somebody's, you know, we get patients who have surgery like all the time, right? GIs are different things. So they might be not as opioid naive as somebody else. So 0.2. So if I saw that you were on a 0.5, I'm not going to call a provider. I mean, it might be something that the patient is fine to be on, but I'm certainly going to be assessing their respiratory system, right? So what if you walked in on this patient and they were breathing at 6?
Oh, I turned up, yeah.
Depends on medication.
Yeah.
So, hold on there. Do I have to shut the pump off?
No, you just take the clicker away.
And you could take the clicker away. When is it more important to shut it off?
If it has a continuous
It
use.
has
Oh, that's
continuous going.
Mhm.
If I take the clicker away from you, you're not using it,
Mhm.
right? And then what are you gonna do?
Give her that medication.
Give them which medicine?
Naloxone.
Naloxone, because it's there. Do I have to call the provider first?
No, it's
No.
already.
Because what if I go call the provider?
He did.
Then what? Then their respiratory rate is what?
2.
Or they're dead. Yeah,
But I have a random question. If it, I know it's always ordered, but if it wasn't, what is that one of those things where it's like you could disable them or?
that's not one of those drugs I can just pull out and give. No,
No?
Nope.
Okay.
I'd call like immediately, you
But
know?
if you notice it, you could always call, hey, can you just
Yeah, and I might even say to a provider, if that was my patient for the day, and I go, can I just have some naloxone? I'll tell you, the majority of patients do fabulous with it. They don't need the naloxone. It's pretty rare. But when it happens, you want to be prepared, right? Okay.
For the, so with that, with the agitation
Mhm.
thing with that.
Say that again.
Naloxone, like.
Oh, how they wake up and they're very
Yeah.
agitated. Yeah, they're not super happy with you when you wake them up. So, PCA, you guys got, let's talk about cancer pain for a minute, okay? I did talk briefly about it. What might we ask? A PCA question? Potentially an epidural, but that's probably less common than seeing a PCA. Or, what other medication did I see? What? The patch.
Yeah.
It's often used for cancer pain.
What was it?
The fentanyl patch.
The phone.
Why? Why is fentanyl patch a great thing to use?
It's a long,
Yeah.
It lasts a long time,
Mhm.
and it's a strong,
and it's a strong medication, and they don't have to ask for something every few minutes, right? I might also use a fentanyl patch for somebody, when we think about cancer pain, we're really thinking about a lot of it related to home care, right? A lot of our cancer patients that are kind of dying aren't always in the hospital in acute settings, right? So what if your patient can't handle oral meds, right? Because there's some good oral meds I could give them, some long-acting, some morphines and things. But if they can't have that, fentanyl patch is great. So what do you want to talk to me about with the fentanyl patch?
They gotta get on something before they get on fentanyl patch.
They
Yeah.
do,
Something
yeah, they
about
do, because it might take a few hours, up to 24, for that to start working. And I know I've given this example in class when I first started teaching in this course, because I had been in 111 first, and I started working per diem on my unit. I had a patient who was so sick, and I had 6 patients, and I was just like, every nurse out there. I'm at my wit's end because I got this one guy who was so much pain. And he was taking all of my time away because I was giving him a push med, and then I would go back in and I'd have to give him breakthrough. It just was so much. So finally we called and got an order for the fentanyl patch. And actually, I don't know if you guys have ever heard of it, like the ENIT team, or they have like these teams of ICU nurses that have tons of experience and will come and assess a situation before they have to call the provider, and then we'll get the, so anyway, they came over, got it, and I was like, oh my God, thank God they're here, like I knew what we needed. So, some knucklehead though, DC'd all other narcotics. So somebody went ahead and put the fentanyl patch on for me, because I had 6 other grapefruit. And what do you think my patient in that room was?
Agony.
And then you couldn't get a hold of anybody to get something else to load into this patient. So when you're thinking about fentanyl stories, think about Jackie's patient, who I've never, other than my patient with pancreatitis, this little thin woman who is an alcoholic, like I've never seen such pain before. And I worked in the burn unit. Like rip skin off of people, right? This guy, I couldn't do anything to, so there's your story. That's what you remember, okay? Okay. Pain-wise.
You can't reuse the same spot, you have to put it in a different spot, you have to wear gloves.
Oh, I'm like, what is she talking about? You have that, what? Yes, you have to move it. How many nurses?
2 nurses.
2 nurses, just like screwing in your light bulbs, right? 2
You
nurses.
said up to
Screwed in.
24 hours, right?
Yep.
Oh, how many days does it last? Like 7?
It usually, they usually order it to be changed every 72 hours.
Okay.
Yep. Okay. So let's look at this last one on this page, and then I'll try to answer some questions and chit chat with you guys a little bit. So skin cancer, so squamous cell. There were pictures there. It's a little grosser. It's the one that has the horn on it. Again, might we ask you a question that, yeah, but I wouldn't spend hours memorizing. Because remember, we don't ask you a lot of knowledge questions. And if you can say to me, oh, it's got the horn and it's scaly, that's knowledge. And we need to know that you know what to do once we've had the problem. So this patient, squamous cell, they did an excisional biopsy. So what does that mean? There's a lot of ways to biopsy.
They take a little shaved piece off and then they go and analyze it.
They analyze it to see what it is and if they got it, okay? And then they'll know it's a basal cell, it's a squamous cell, or it's a melanoma. So from there, so he had an excisional one. So the excisional one is not the shave.
It's not the shave.
Excision means what?
This is the whole thing out.
Yeah, so if this, I know not everybody can see this, but if this is my lesion, this is excision.
Oh, that's right, it took more tissue around it.
Taking more tissue around it.
Yeah.
What are we worried about with this kind of, with any biopsy? Bleeding. Don't tell me wound healing. I don't even care if you're diabetic. I don't care about your wound healing. Every time we have any kind of biopsy. Now, are the majority of biopsies pretty benign? When I say benign, not that they're not, but are they like nothing happens to them? The majority of them. But there are arteries everywhere in people's bodies, and people can bleed to death very easily. So, how do I assess for my patient's bleeding after a biopsy?
Vitals.
So vital signs and checking the dressing. Yep, I want to make sure that we do that, okay? All right, so then he had a flap. There's nothing any different with his flap. He had a free flap. That means they took a chunk, they took some fat. I don't know, I don't even know where they're taking it from. But we want to make sure that it doesn't occlude, okay? All right, oh, I know. Here's the one. Talk about this a little bit. Let's talk about a thyroidectomy for a moment or two. So, why would somebody have to have a thyroidectomy? Well, of course, we're studying what?
Cancer.
There are other reasons, but don't memorize those because why? They are nursing, 214, that would be a goiter. It could be, we're having trouble regulating you with your meds, so problems with meds. So don't worry about that. We're really just thinking about it for cancer. Okay? What does the thyroid do?
Regulate
Your metabolism.
Yeah, regulates my metabolism. So is it kind of an organ? I'm going to trick you and say, does somebody need something to help with their metabolism? I either need what? The organ or what else? Or
Hormone therapy.
right? I need hormone or I need meds. Pardon me? Hormone therapy like Synthroid, levothyroxine, or the 2 names that you probably would see. Okay, so they can take out all of it, they can take out part, whatever, or they can take out the whole thing. Okay, tell me where the thyroid gland is.
Anterior part of the neck.
Anterior part of the neck. Yep, exactly right there. And probably you have gone to have a physical, And somebody puts their hands there and swallows just to make sure they don't feel anything unusual. Yep. Okay, so what part of my body kind of is it wrapped around?
Your
Your
vocal,
My trachea,
Yeah.
right? So this is my trachea,
And then
and
the
I'm not
voice
gonna
box
even,
is above.
yep, I'm not even gonna draw it well, but that's the front. Okay, so that's the thyroid. What's around the back of my thyroid? Parathyroid gland. Okay, parathyroid gland. And what is it, what are they responsible for? What do they help with?
Calcium.
Yep, and how my body uses calcium. So they try not to remove them during surgery. They will try to leave them there. But if you ever looked, and I always think when I tell you these things, it's always good to go back and look, because if you see the visual attached to it, it'll make sense. They look like these little globules of just fat. They look yellow and fatty, and they're easy to remove. Now, if they know they've removed them, they can go back in and transplant them, but sometimes they just don't know. So we're worried about this patient's calcium, okay? What else are we concerned about?
Their breathing.
Yeah, we're worried about their airway and their breathing and of course their circulation. So what would this patient have at the bedside?
The
A
trachea.
trach setup. Yep. What does that mean? Oh, I got some stuff in there that I can clean you and cut you and stick a pen in there to help you breathe. Well, not a pen, you know. That's only on medical. Right, so they would have a trach setup. What else?
Suction.
Probably a suction setup and making sure there's oxygen handy, okay? So airway breathing, circulation. How do I manage circulation in this patient? What do they have in them?
Oh, a tube,
Which tube?
the drainage tube.
They have a JP drain, okay? Why? Why do I want a JP drain coming out of this person's neck? Because I don't want fluid to accumulate. Where would it accumulate? Inside my throat?
No,
Around the outside of it? Because that's where this,
That's where
right?
it used to be.
You're not inside my throat on this surgery. You're not down in my throat. This is around my throat. So we don't want what? Fluid to build up, because what could it cause?
Compression.
Problems with breathing.
Mhm.
Does that make sense? Okay. So this is to prevent, fluid, hematoma from building up and causing airway problems. Okay. Okay, so we kind of got the big ones here. Yeah, pain, infections, bruise, who cares? Okay. So what do I do with this person post-op though?
You gotta sit them in semi-collar
Okay, so they have to be, why?
so that they don't extend their neck.
Yeah, we want to make sure that they're not overdoing that neck, putting tension on. What else?
Monitor for bleeding.
Yep, bleeding.
Mm-hmm.
So what else? Signs and symptoms of what?
Hypocalcemia.
Yeah, which I'm not even going to talk about. It's on my PowerPoint.
Cats.
Cats. Hypocalcemia, you guys have been reading, okay?
So
Because we could put that on a test. Your patient is having blah, blah, blah. Yeah.
it doesn't say it in here, but I expect you guys are gonna quiz us on the diagnosing, like ultrasound or fine needle aspiration.
So I think I mentioned somewhere in there, but there's a lot that's mentioned, that when we talk about you mean when we're talking about biopsying?
Yeah.
We probably wouldn't ask the distinction between the punch biopsy and the cone. And
Okay.
what we really want to make sure that you know is anytime we have one, like what you're doing and how to especially manage this one. Okay?
Question, if it's stated that they did not take the parathyroids, would you still
They'll still
anticipate low
check.
calcium?
Yep.
Okay.
They will still check, but we're more concerned, and sometimes we don't know, Hamida. We might not know until we get a calcium back and it's like really low, that they came out.
What would they do, medication?
Yep, yep. The other thing, somebody mentioned vocal cords.
Mm-hmm.
Okay, anybody know what is problematic?
Oh, didn't say voice change?
Yeah, they could have some vocal changes, and sometimes they're just temporary. And again, I wouldn't spend hours thinking about this. When you see it on a test, think about what organ they're talking about and the nerves that are running around it. And then you don't have to memorize it. Okay? So they might have some vocal changes. They might be hoarse. And it's temporary or permanent, and sometimes we may not know, because these people are usually only in the hospital for one day, and they usually go home with their JP drain. Yeah,
If they have to have total removal, we do teaching for this hypocalcemia and levothyroxine.
yeah, absolutely, absolutely, and luckily for you, levothyroxine is 214. So that's one other medicine you don't have to worry about. So this sometimes the first 24 hours you can hear that their voice sounds a little, there might be some swelling around the vocal cords, but usually patients do pretty well. I've taken care of a few of them and I have rarely seen any problems. I've rarely seen, these patients do really nicely after surgery. I don't think I've seen any hemorrhage, no hematoma, like they do well.
So you would anticipate that it would be expected, it wouldn't be something that you would have to assess more because of airway.
What do you mean, so
The fourth-
expected versus unexpected? What do you mean by expected, that they're gonna be hoarse?
Yeah, like wouldn't you expect
No, I
that?
don't think that's an expected find, that would mean that everybody gets hoarse. Or has, expected would be what?
Fine.
That your vital signs are stable, that you have a JP that is draining sanguinous liquid for 3 days, that you still have some pain, that you, unexpected, right, unexpected means it's a problem, okay? Unexpected doesn't mean a side of, like, do you know what I mean? It's, I guess if you can use that example that we talked about the other day, where we said expected versus unexpected when we give somebody an opioid. Expected would be vital signs stable, O2 satisfying. Unexpected, even though it happens, gosh, that's a problem. Yeah. Once you have an unexpected finding, then you have to figure out what's my nursing intervention to manage that.
For the patient who has a thyroid, are there NPO or clear liquids or soft
Yeah,
diet?
they'll go on clear liquids, after surgery, they'll probably go home, but they might not feel like it, not because they're gonna have a sore throat from the thyroid being removed, because that was, I mean, it could hurt, but that would be more what? Sort of surgical pain? Could they have discomfort inside their throat? And why would they have discomfort inside their throat?
The swelling,
Not from the breathing tube.
the swelling?
The breathing tube.
Oh,
Yeah.
Oh.
Yeah, however, I'm not even sure, like a thyroidectomy patient who swallows may not be able to differentiate, right? Where that pain is coming from, right? It might just be like, kind of hurts when I swallow, but they can't say that it's the incision versus the tube or,
A lot of times it's just a kind of back throat.
yeah,
I've heard that down here.
yeah.
Even though they'd be on, a clear liquid diet, when they have that pain, we'll still encourage them to like, maybe practice their swallowing reflex so that they can
Yeah,
advance
you
to
could,
a
yeah,
better
yep,
diet.
probably the more they do. Now, the other question that I've seen floating around out there, practice question, is should this group of patients do coughing and deep breathing?
No,
Yeah.
no.
No?
So
No.
have some of you seen questions about that in any of the HESI?
Not in the HESI, but yeah, we saw
I
some.
would say for the most part, and I wouldn't ask you this on a test, but I've seen it floating around. Thyroidectomies typically can do some of that. We're probably not gonna be too vigorous with it because we worry about sutures. Tonsillectomies are the ones we tend to worry about with coughing and deep breathing because the sutures are now inside the throat.
I coughed after I had mine, I started choking on water, and it was just like a pulling pain, I never felt anything like
Did you have your
that
tonsils
before.
removed as an adult?
Yeah, I had them removed like 3 years ago.
Yeah, it was horrible, right?
Yeah.
Sorry if any of you as adults have to have them out, but children, God, they do fine. They go home, they're running around. Adults, it is horrible.
Yeah.
Horrible. And were you in the hospital for 24 hours or they
No,
sent
they
you
sent
home?
me home, but I was like in pain for like 2
Yeah.
weeks.
So they didn't put you on steroids? Like prednisone at all?
I don't
Decrease
think
any
so.
swelling? Yeah, it's bad pain.
They put me on liquid morphine.
Yeah.
So, yeah.
How nice for you.
Yeah, maybe I'm not good, but.
Here's my PCA to take home with
Yeah.
me. All right. Let's just review this quickly. All right, these tests over here. What are you looking at, Nick? My picture, is everything good and clear?
Yeah.
Just wondering because you're staring at my picture there. Okay. All these diagnostic tests or screen, right, diagnostic
Diagnostic
or
screening.
pap smear can do some.
Well,
It can give you the HPV that would be likely the cause of the cancer, but then they're gonna have to go in and take out a piece of the tissue. But, so talk to me about a bronchoscopy. Should you even need to study this?
No.
No, what does it sound like?
Sounds like a
Sounds
scope.
like endoscopy, right? So tell me something about this.
It's a scope.
It's a scope.
It's
They're
a
looking at
scope.
everything.
So look
NPO.
where?
The lungs.
Down into the lungs. Okay, for what?
Cancer in the lungs.
Cancer or anything else, right?
Mhm.
Okay, so NPO, what else?
Is this one also conscious sedation?
Sedation, excellent. What else?
They'll have like the stuff sprayed in the
yeah.
nose.
Yep, so they want to have some lidocaine in their throats.
We also need to ensure that the gag reflex is there.
Yep, check bag. Before what? Sending you home?
Mhm.
Now, this is where that expected versus unexpected. So you come out of a bronchoscopy,
Mhm.
right? What do I expect? I expect that you may still have your absent gag reflex. Why? You just got,
Yeah.
just like I would expect that you might be, slightly sedated. I still would expect that your vital signs would be stable, right?
Mhm.
But that you might be sort of sleepy,
Mhm.
okay? Okay, anything else? I think we missed something up here that's pretty
The
important.
perfusion, thinking
The
that.
what?
Oh, yeah.
Oh, yeah, worried about perforation, excellent. But even up here, something we forgot.
What did we forget?
ABC.
Well, yeah, ABC.
So, what do you mean, the timing?
No, not about NPO, but something like, we know it's a scope.
Mhm.
NPO, conscious sedation, what? Consent.
Oh.
Oh, duh, duh. Okay, so they'll go in, they can do what's called a washing, they can go in and clean, they can take out sputum, they can do a lot of things. In our case, they're gonna be doing what? Probably taking out a piece of tissue. What might this patient see when they go home?
A little blood?
And they cough.
A little
They
blood.
might see a little bit of blood,
Mhm.
yeah. But again, we always worry about hemorrhage, okay? Okay, I did talk about, I think we're done with biopsies, right? What are we worried about here? Bleeding. Okay, pelvic exam versus pap smear.
Pelvic exam is feeling around, basically.
Just feeling around.
Mhm. Looking and feeling.
Yep. Yes, it is also looking. And it is kind of one of those awkward things that most of us women have had one, or 10, or 100, so we know what they're doing and they're looking at. I have been on both sides. I have done plenty of them as a nurse practitioner, so I know what, but I think for a gentleman, like to even Google that would seem kind of awkward.
I did before you came in.
Yeah. Was it a little awkward? Yeah. I would, if I was gonna put that in, I probably would say clip art. I don't think I wanna see any, but, so a woman, like, we gotta talk about this is medical stuff, right? We're legs up in stirrups, men do that when they have vasectomy, so there you go. Nobody has anything any different. Legs up in stirrups, naked from here down.
Very vulnerable moment.
It is a vulnerable moment. It is very vulnerable for that, yes.
They are looking into your soul.
They are. And I had the most awkward time I've ever, I'm not awkward doing this, I don't care, I'll do it, was when the patient took, I mean, we got a sheet up there, there's a reason, I don't want to see you. Just took it off and wanted to talk to me. Back up, I don't need to talk to you while I'm doing this. It's a little strange. Okay, so they then will take hopefully a plastic and not metal speculum, and I'm sure that some of you have seen the speculum or heard of it, but it's, it's too, almost look like a,
Like a duck.
Clay.
yeah,
it
what?
looks like a duck.
Like a duck bill.
Like it's, exactly, and so we put it in and we
Crank it open.
break it open, and what can I see? I can see the walls of the vagina, and I can see the cervix, and that's pretty much it. I can't see into your soul, but I can try. The cervix in somebody who's never had a baby, super duper small, it's like a pinhole. Anybody who's had a baby, that cervix, it's not gonna be huge, I can't put a fist in there, can't put anything, I can put,
Is it a walnut?
it's not even, like this, it's just a slit, it's still very small, okay? Those are the things I can see. I can see to make sure the walls look good, I can see that this outside of the cervix looks pink and moist, and it's not littered with HPV, discharge, whatever it happens to be. And at that point, we just take a little brush and we go around the inside of the cervix one way and then the other way, put it on the slide and off it goes, okay? If someone is experienced, it can take 2 seconds. I know it seems like a lifetime. Speculum comes out and then the provider will put in a couple fingers.
Feel around.
What can I feel? Not a whole lot. You can tell if the uterus is tipped a certain way, because sometimes if it's posterior, like, that can be problematic for having a baby. Not problematic, it's just good to know. I can feel if there's any tenderness, and if the person is super thin, and I can go up on one side or the other, I can feel an ovary or two. Doesn't mean they don't have ovarian cancer. Can I diagnose ovarian? No. Okay, so that's it. However, as you age, they will do what's called a bimanual exam, which means finger in vagina, finger in rectum at the same time to feel the wall in between to make sure there's no.
No, that's not happening.
I'm not telling you to scare you, but everybody needs to know. You ladies have an advantage. You've had it done. They need to have that same idea. So if there's a test question, right, we don't show you a video on it. But anyway, as you age, just to make sure that the wall between is okay. Okay, pelvic exam. But while they're doing that pelvic exam, what did I say we did?
Yep, you took a little sample.
Yep, I
that's
take the
testing.
brush, and here's this is what it looks like, and I go around one way, go around the other way, and we put the brush in there, and off it goes, or you put it on a slide, and that's it, okay, and the patient is finished for the day. Get back to pap smear results, and it might say everything looks normal. Sometimes you hear the word dysplasia, which means abnormal cells. You might see HPV, blah, blah, blah. If all's normal, that's fine. Women wait a year, typically when they're sort of in those younger years. As women age, every couple of years is okay, but it's so interesting. Last time I went for mine, I guess I just didn't even think about it. She had just diagnosed a woman in her 70s who, husband had passed away quite a while ago. She hadn't been with anybody else, and she developed HPV. It came out latent in her. So people should still be having it done. Okay.
Aren't there like couple types of HPV or something?
Oh, there's lots of them, and I forget which ones. I can't remember the numbers off the top of my
I
head.
think
There's
it's
two
12
that
or
are
something.
It's like
two that
16 and 18.
yeah, two that are the big offenders of causing cancer. Okay.
Is that what we get vaccinated for?
Yeah.
Okay.
Exactly.
There was no vaccine when I was younger.
Yeah.
got
I
it
remember
done,
when
it was
my
like first round.
Yeah,
Yeah.
like,
When it came out.
Well, yeah, my daughter's 26, and it was kind of new, and she
Yeah.
was like 14, and it was brand new, and my daughter, like, she's super tall and very, very thin. She didn't get, and I hate to tell you this, she didn't get periods, and she was like past 16. But she ended up with lots of, and she doesn't have an eating disorder that girl can eat, but she ended up with like bone problems because of it. She's fine now, but, where was I going with that? Why did I even tell you that story?
This vaccine.
Oh.
Because we're talking
Kind
about
of like,
like,
oh, should we get the
vaccine.
vaccine? No, my God, she's still playing with Barbie dolls. She's 14, she's not getting the vaccine, she doesn't know about sex. Duh, right? So I didn't get it for her till she was 16, but it was still just brand new. And it wasn't that I didn't think it was gonna be a problem. I'm not an anti-vaxxer, but I was just like, I don't think she needs it yet, like even just emotionally, but.
As soon as I say cancer, you'd be like,
Yeah,
the vaccine.
They told me it
God.
was for warts.
I'm not that against it.
Well, those are caused by the virus.
Oh, okay.
Yep.
That's all I heard from my doctor.
Yeah, you're like, warts.
I got my
There you
house
go, Google a
well.
picture of that.
Yeah, no,
If
they
you wanna
showed
see
me a picture, and I was like, oh, good.
All right, what else in those last 3 minutes? Rihanna,
yeah,
if you are struggling with the CBI,
I did the first time too.
I know you did. Does some
Okay.
kids feel like they can explain it?
I
Okay,
said-
Jenna.
Well, the thing that confused me about it was when, like, how it says 7 a.m., you have 2,000 milliliters. Like, that's the part where I get confused, but then when she, like, it's not the same bag as the Foley, it's a different bag, so I just think of that as, like, an IV now. And
Yeah,
then
because it is in an IV bag
Yeah.
next to the patient, you remember that?
Yeah.
Okay,
I was getting confused because I thought that you went in at 7 a.m., there's 2,000 milliliters in the,
Yeah,
the Foley
that's
bag,
what I'm
and
like,
then
wait,
2,000.
no,
That's why I
okay,
was
so let
confused.
me try to rewrite this again, okay?
Talk money. I think people understand money.
Alright,
Do it as like not even numbers, I think maybe like, 'cause 2,000 and 1,000 might be like, you know what I mean?
Okay, so, patient, right? Foley. CBI, going in where?
The bladder.
Into the
Into the Foley, right?
Yeah.
Which then goes into the bladder. Where does it go after the bladder?
Into the Foley bag.
Goes right out into the Foley bag. So if you follow this arrow, some CBI, well, CBI comes back out, right?
Mm-hmm.
Okay. So when I go in the morning, shouldn't I know what how much is in there?
Mhm.
Otherwise they can't do their I&O, okay? So let's say at 7 a.m., they have 1,500. Does that work better, James?
I just meant for the,
Oh, for the
maybe
answer?
For the, like when you come back.
Oh,
the-
okay.
The second credit.
All right, so they got 2,000 in there. That is my credit. It just means
The
that's
beginning.
how much I have in the bag,
In the CBI bag?
Yep.
Okay,
in the CBI bag.
Okay.
Okay? The order said, keep it running,
Mm-hmm.
run, 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 so that, oh, can somebody listen and erase at the same time? Yeah, thank you. But you can watch while you're erasing. Keep it paint to clear.
Right.
So, oh, sorry, you
Sorry.
can, if you get over there quick and erase it in a minute, okay? So, it's going into the patient. At 12 noon, I go back into that room. Now, my CBI, give me a number, James.
800.
My CBI only has 800 of credit. So
Okay.
what does that mean? Where did the rest of it go?
so 1,200 went into the
Right,
patient.
so, but I don't even have to know that, I just have to know that it all went in, it went in here, right?
Yeah.
Okay. Now I have to empty the Foley,
Mhm.
okay? How much is in the Foley, James?
At least 1,200. Oh,
So 1450.
1,850.
1850 is in there. Is that all urine?
No,
No,
it's out of good.
What else is in there with it?
so it's just
CBI.
CBI in it.
It's urine plus CBI.
Okay.
But I only want to know the urine. So
that
I
would
have to
be-
take my urine, which is 1850, or I should call that my Foley,
Mhm.
right?
Yeah, Foley.
And then you would, so then subtract the 1,200 from it.
So 650 is the urine.
Okay.
Take a picture of that, bam, that's
Yeah,
way
that
better.
one I need a picture of.
So, Jackie, the process actually is, if you're concerned about, I mean, obviously you're always concerned about the gym. Did they ever do anything like an option or
Oh,
to
because
prevent that? or no?
No, I've never seen that, no. When would a patient who has had a radical prostatectomy might need an ileostomy is if that cancer had spread.
Yeah.
And it had attached somehow to the bowel.
And also, just as kind of like a side note, my mom actually had a bronchoscopy maybe 2 weeks ago.
Yeah,
Two things that I thought were weird. One, her throat is still numb. Yeah, right.
that's interesting.
Yeah.
Yeah,
So her, I don't know, her provider's kind of suck, honestly, but, the provider, I don't know, she said that for the bleeding, for the coughing, she said a teaspoon is okay, but a tablespoon isn't. I understand the thinking, but I don't know how the hell my mom's supposed to know that, you know?
yeah, I know.
It's weird.
I think yeah, that is typically what they'll say, like a teaspoon just being smaller, like if you
Yeah.
pop up something that's a tablespoon. I've heard that before. I think in theory, it's really not that big of a difference between the two. You know what I mean? Like, I think it's more for me, if you're popping up tablespoon or teaspoon sizes frequently,
Yeah.
that would be concerning. I don't think any patient really has any clear understanding about what a teaspoon versus, a tablespoon would be. I think that's, and your mom's a nurse, right?
I called on both my mom, once my stepmom.
Oh, what'd you say? So she wouldn't know, right?
Right.
All right, how are you feeling?
Great.
Better. You guys seem to really have a good handle on, most of it. A lot of things you gotta go back over, those little things, right? Did everybody get, Melissa, did you guys get this last picture here?
Yes, I got it.
Okay, everybody's good with my better picture?
Yes, thank you.
You're welcome.
Because like, it comes out all
Hello.
silly